I just wanted to say thanks first off to Natasha and Genetic Alliance for inviting me and for bringing such a diverse group together, as Nancy pointed out, and to Nancy for a great talk to kick this off, and explain to us sort of what actually happens as those making the decisions decide whether or not to bring new conditions onto the list of things that should be screened at, in a population-based public health program. I thought I would try to add a little bit to the discussion with some thoughts about what might happen, how we might start to think about other conditions as next generation sequencing meets these population-based screening programs. I am not a clinician, I'm not a geneticist, and so I can't speak to you with any authority about particular conditions. I don't know the medicine well enough to tell you, tell you specific conditions that I think should or shouldn't be added. But I think the reason that Natasha invited me to talk in this little space is partially because we've been spending some time talking to the next generation sequencing industry about how they sort of see things moving forward as their technologies hit the clinic generally, not just with respect to newborn screening. We haven't talked to them specifically about newborn screening, unfortunately, but we've gotten a little sense of that, and we've also done some work with Genetic Alliance talking to recent mothers and prospective mothers about sort of their general thoughts about newborn screening. So thought maybe we could sort of put some of those observations together to think about, what clinical questions might drive the expansion of public health screening, newborn screening as the technology arrives. So as we sort of talked with the next generation sequencing industry, and we've done about 15 interviews so far. We've got a few more, all relatively recently, last 3 months. Pervasive opinion, and of course this is their job to say this, is that, but fairly pervasive opinion that either exome or genome sequencing or maybe panels will eventually sort of be the technical way that sequencing is done for many or most clinical applications. That at least the next generation sequencing will sort of touch each sort of genetic testing at some point in the process within the next 5 to 10 years. So that and stocks go up. But so I'm asking us to sort of I'm just going to operate in the sort of fantasy land where we've reached that point that the folks we've been talking to talk about, where there are double rainbows every day, and unicorns police the universe. And well, that's not a unicorn; it's a safety unicorn with no horn, I suppose. So, which is good for children, newborns, no pointy objects. So, in this fantasy land, let's assume just for a minute that either using panels of genes, that is, a panel of maybe 200 or 300 genes that you select that you can sequence all at once, or whole exome or whole genome sequencing. Let's assume that for newborn screening, one or more of those technologies becomes fast enough, accurate enough, and cheap enough to warrant use in newborn screening. And we may be there. I'm not a technology expert. I think some of the folks in the next talk, I think, may want to speak to this. But let's just assume for a minute that we've reached that point, and that the public databases about the conditions, the phenotypes that we're interested in, are informative enough to allow us to interpret the data that these technologies can gather information on. So in this glorious future, we have a lot of information available, and in the words of one of the industry people we interviewed, you can look at whatever you want for whatever disease. You have the entire genome in front of you. So that seems, a little optimistic. Rainbows and unicorns, safety unicorns. So obviously, newborn screening is not going to look at, probably not going to look at whatever disease for the entire genome. So how might we start to, pick at conditions to add? And I mean, a couple things about the process that, Nancy's group, the group making these decisions has gone through. Number one, it's a very rigorous process. Number two, there's a lot, it's highly evidence-based. It's not just, and those things shouldn't be thrown out the window. And I don't mean, so as we consider adding other, and number three, most of the conditions that have been added since that initial list was formed were on the sort of initial list of, I think it was like 84 conditions that were originally considered to be put on the list. Most of the things that have been added came from that list, if I'm not mistaken. So maybe one or two. So that's probably a pretty good list and where your most likely candidates are. But again, sort of thinking about, the rainbow world, maybe we think about expanding. And we talk a bit about what the public wants, and not that whatever the public wants, the public should get, but we probably shouldn't, give results that the public absolutely doesn't want. We did a survey of recent prospective mothers. 98% of them wanted to get newborn screening results for conditions where early diagnosis could improve the baby's health. Not surprising. 72% of them said newborns should be screened for conditions where early diagnosis may not improve the baby's health. So that's a fair, almost 3/4 support getting that kind of information. Again, that doesn't mean we should give those things back, but it means, I think, and it also means 25% do not want that information, which goes back to questions of consent and informing parents of what they're going to get. So if they truly don't want something, maybe they don't get it. And again, this all has to occur in a public health, population-based context where you're dealing with not 10 people, but 250,000 people a year. So, but I think from the public standpoint, Pandora's box could be open to go beyond, say, that list of 84. And just to show you a little bit more in detail, we asked recent mothers if they'd be interested in learning about adult onset diseases and traits for their newborns. We said someday it might be possible to screen for certain traits that develop later in life. Assuming you had a baby today, which of the following traits would you want your baby to be screened for? And we started off asking them about type 1 diabetes and explained that that's, so we had a comparator, explaining that that's, a childhood disease. So you can see that 75% of moms said they would want information on type 1 diabetes. And about half, between 50 and 70% of women said they would also be interested in getting information on things like Alzheimer's, colon cancer, type 2 diabetes, heart disease. Again, the interest is there. That doesn't mean that there's an obligation, but the clinical questions won't be the only things that drive what newborn screening does. There are certainly market pressures, those design chips and tests, and you can see it just in CF screening. Sometimes more is viewed as better, whether it is better or not. There's a recommendation that we screen for a limited number of CF mutations, and some companies sell screening for the whole gene. Again, I think sort of the door's open, and I do think it's worth paying attention. At the bottom, 20% of women said they don't want any of this information. We asked about some traits too, which we thought were interesting, and far fewer, but not in a substantial number, interested in sort of recreational kinds of things. But 20% wouldn't want this. So, I mean, Nancy pointed out, I think some of the so how would you even begin to choose what does one present? What could one entertain presenting? In Fantasyland, that sort of goes above and beyond. If you could sequence lots and lots of things, and these are some of the original criteria that were used to include a condition. The screen's got to be sensitive and specific. You've got to be able to, do a lot of them. 200 plus a day is, it's more like 2,000 in New York. You've got to be able to do it at cost. It has to be feasible from the standpoint that you need to be able to collect the sample easily that you're going to analyze. In this case, I think we're talking about a blood spot. Multiplex testing to sort of get a lot of bang for your buck, and similarly one analyte, and being able to look at one analyte for multiple conditions. So this was the original set of criteria, and again, in Fantasyland, I think we're sort of saying those two, throughput and cost. We're sort of saying, let's imagine we've solved those. And, I think that next generation sequencing also sort of addresses these last three criteria, and might could pass muster for the last five. Sensitive, specific screens that can be interpreted, that clearly separate people who do and don't have a specific phenotype, that's not going away. So that's a criteria that needs to be considered now, going forward, I think, no matter what. So those are sort of criteria that describe a bit about the test and the disease. These are more sort of about the disease. The criteria that you were going to look at relatively high incidence conditions that would typically go undetected otherwise, and that created high health burdens. And those three things were all sort of, are all, I think, really sort of bang for your buck kinds of measures. Things that are very, 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 very rare, that you might detect, a clinician might detect otherwise. We only have limited resources. So, but if you can add more, if you've got a chip and you can add more diseases, I would posit that maybe, add more diseases for little or no costs, although there's certainly downstream costs, that maybe those sort of fall away a little bit as criteria. But you're left with these other criteria that are all about sort of the pragmatism of getting this information. Is there something that's simple and available? Because it's population-based. Tons of, everyone's getting this. So you've got to be able to do something simply that's available, across context when you get the information. You need the expertise, to be able to deal with it. Cost, efficacy, primarily you want to benefit the child. Family and society benefits maybe later, and you need to be able to confirm that stuff. So, all that's, I think, sort of boils down, and I don't think those things are going away either, no matter what technology we use. So, you want to be able to look at things that, diseases where you can really get an accurate assessment of a phenotype based on the screen, where there's simple, cheap implementation of next steps across populations, dealing with common, information that's useful for common diseases certainly might be interesting. You want things where the next steps incur low risks of harm and where you might actually affect disease progress or treatment. So, I was just trying to think of what types of disease categories or screening might sort of, that are not really on the list right now, might be used, could be included in Fantasyland, that sort of meet those criteria that still, I think, stand out. One is, maybe a broader range of genotypes that might serve as either diagnostic or as a differential diagnosis, and maybe not just for childhood diseases. One thing I thought about was celiacs, and I really don't know about doing it with gluten. I'm not sure what that would entail. Celiacs do it gluten-free, but celiac disease, if you go to Whole Foods, is one of the most common conditions apparently in the world. It's really stunning. But the majority of people with celiac disease have either the HLA DQ2 haplotype or the DQ8 haplotype. So it's not that testing for those haplotypes would diagnose children or infants who will go on to develop celiac disease, but if you had that information, if you knew that you, for example, didn't carry either of those haplotypes, and you entered that into medical record, and this goes back to systems. You've got to, this is, if you're saying this is going to be part of the newborn screening system, this is something that would have to happen. If you could store that information and you knew, yes, I do have that, or probably more importantly, no, I don't carry those haplotypes, and you entered that into the medical record, when a person later developed GI problems, you might be able to look and at least very quickly rule out celiac if they don't have those haplotypes. And from my perspective, you would, save a lot of Thanksgivings by by doing so, because several of mine have been ruined. Someone who didn't have celiac but thought he did. So anyway, that is to say that maybe there's some diagnostic information there, or information that could be used later to speed, makes more simple diagnostics, relatively low-risk types of information. Along the same lines, we may be able to short-circuit diagnostic odysseys, and I know this has obviously been talked about in the community for a long, long time. Short-circuiting diagnostic odysseys for families and their affected children, even when treatment's not available. It could save resources, healthcare resources. It could help families with very difficult, expensive situations. But again, going back to that graph, sort of 72% say they think they would want something like that, 30% wouldn't. You need to ensure that the sort of parental understanding and consent is there. And going back to our survey, I'm sure all of you know, that is easier said than done. This is just the percentage of recent mothers. So they had a baby who was screened in the last 2 years. 33% of them hadn't heard of newborn screening. So before you get to understanding it, so awareness is low. Minnesota's on top of it, but a lot of work to do. So if you're thinking about consent and understanding for new conditions, that's not an insubstantial hurdle. And finally, the last maybe set of conditions that I thought about, thinking more about adult onset kinds of things, would be maybe pharmacogenomic data. We heard from a number of the industry people that they feel like this is a growing market for them, that they see enormous numbers of clinical studies going on that are focusing on pharmacogenomics in order to stratify their patients. On clinicaltrials.gov, there are 194 studies in the United States doing pharmacogenomic. These are clinical trials involving pharmacogenomics. And that's a list of conditions or a partial list of conditions. A lot of them are oncology phenotypes, but depression, alcoholism, some childhood conditions, asthma, morphine tolerance for kids getting tonsillectomies. So that could be perhaps, again, a sort of low-risk, potentially useful piece of information that one could collect to add value to, next-generation sequencing that could go into a medical record. Stratify populations ahead of time before disease that could improve, their prescribing later in life. I think it could be a relatively low-risk, medium-reward kind of situation. Whether it belongs in the newborn screening panel, probably not. But, I'm just putting it out there. So, just one final thing. And back to the sort of the criteria that won't go away is sensitivity and specificity, a high quality test. When the women say that, I would like other information, I would like information on these diseases, the assumption is that when you give back that test result, that association is, that about the phenotype. Whatever test you did points directly to that phenotype. High quality information, false positives are not good. So newborns, the biggest worry that women had about newborn screening is that it might not provide accurate information. False positives, worrisome. We asked about willingness to bring on a new condition, a test that was had 90% positive predictive value and one that had 60%. No matter how bad the condition was, the one with 60% far less tolerated. So the tests have to be of high quality before you think about doing any of the nonsense I've been talking about. Whole genome, I think, testing probably will become a clinical standard at some point, but now we've got a high number of false positive and unknowns. We need better databases to accurately interpret the information. And as one person said, I think the burden of the data right now is greater than the value that would be added. But I don't think it hurts to think about fantasy land. So thanks to my colleagues, to the Alliance, Natasha, Sharon, and to Nancy for helping me talk me through this yesterday. I hope I didn't go on too terribly long.